Dr. Marathi, thank you very much for the kind introduction. I hope I can be heard clearly despite the long distance. I would like to thank the organizers very much to invite me to your annual conference, and I'm really sorry that I'm unable to attend in person due to the pandemic reasons after experience the great hospitality of your country, and I had been visiting for the first time a couple of years ago. Today I would, during the next 25 minutes, I will address our work in vaccine-induced thrombocytopenia, a disease which is existing approximately 1 year now. These are my conflicts of interest, which will not influence the content of my talk. The talk is structured into 3 parts: the known, which is the clinical presentation of VITT. I will go then into the mechanisms of VITT or VITT and briefly touch the unknown at the end. Thrombocytopenia and thrombosis after COVID-19 vaccination is occurring after all vaccines. All vaccines are associated with a slightly increased rate of thrombocytopenia as ITP. All COVID-19 vaccines are also increased with a slightly increased rate of thrombosis, which is often seen with vaccinations because vaccination induces inflammation, and inflammation is increasing the rate of thrombosis. But adenovirus vector-based vaccines are associated with an increased rate of thrombocytopenia and thrombosis called VITT. And how can one differentiate these? The platelet count and the dimer are the most important laboratory tests for this. The platelet count is low in ITP, but the dimer is more or less normal. In normal thrombosis, the platelet count is normal, but the dimer is slightly elevated. But in VITT, the platelet count is decreased and the dimer is strongly elevated, at least 4 times of the upper range of the normal. And then a year ago, several patients have been observed in several parts of the world who developed thrombocytopenia and thrombosis at unusual sites, especially cerebral vein thrombosis and splenic vein thrombosis. And they occurred typically about a week to 2 to 3 weeks after vaccination. Soon after, 3 papers came out in the New England Journal of Medicine, one from Scandinavia, one from the UK, and one from Germany and Austria, describing these patients. And those of you who are interested in the largest series of patients are referred to this paper in the New England Journal from Sue Peffert from the UK, who has described the features of the biggest patient cohort yet. These are the index patients recognized in Greifswald about a year ago, and a hallmark is thrombocytopenia, but the platelet count can range in a wide range from more than 100,000 down to 8,000 per microliter. As said before, thrombosis at unusual sites are frequent, but the feature which immediately took our attention is the time delay of at least 5 days until the symptoms occur after vaccination. And this hinted right from the beginning that an immune-mediated mechanism is likely an underlying cause. In parallel, in North America, patients had been described to receive not the AstraZeneca vaccine, but the Johnson & Johnson Janssen vaccine, also an adenovector-based vaccine, and they showed more or less the same symptoms and the same features. The prevalence of it is a bit different between the AstraZeneca vaccine and the Johnson & Johnson vaccine. It's about 3 times more frequent with the AstraZeneca vaccine. These are international data, and it is sometimes difficult to judge whether these are only different reporting rates. Therefore, I refer now to the German data because these are the prevalences within the same system. And again, it confirms about a 1 to 3 difference in prevalence. The largest number of patients have been observed in the UK because they use so much of the AstraZeneca vaccine. And the overall fatality was about 18%. The previous notion that probably women are more affected than men is just a bias due to the fact that in Europe, primarily healthcare workers were immunized in early 2021, and the majority of healthcare workers, at least in Europe, are female. Recognition of VITT and early education of the medical colleagues being involved and of the public drastically reduced mortality. The first case series had a mortality of 50% in Australia, who started about 5 to 6 weeks after Europe, taking advantage of all the information. Mortality had been decreased by about 90%. CVST is frequent, but also other major thromboembolic events can occur. And the prevalence is higher in younger than in older individuals. We don't know why this is, but probably it simply reflects that the immune system of elderly individuals is not as good as the immune system of young individuals. That is induced by and caused by anti-PO4 antibodies. It was lucky that there were commercial assays available and out there for heparin-induced thrombocytopenia, which reacted strongly positive with these antibodies. But other than in heparin-induced thrombocytopenia, VITT patients' antibodies bind to PO4 alone. So they are different antibodies. They are not the same as HIT antibodies. And this is also reflected by different sensitivities in the different ELISAs. The ELISA plate-based assays work, but all the rapid tests don't work. This has been shown by the British group, by a German group, and also by a French group. And one can summarize in the moment that the ELISA plate-based HIT assays work reasonably with slight differences, but all the rapid tests and the automated assays don't work. And this is likely due to different coding methods of the ELISA, of the antigens in the rapid tests. The Canadian group has rapidly identified the binding site of VITT antibodies. They bind to the red patch of PO4, and this is identical to the heparin binding site, and this is later important for treatment. While the HIT antibodies, the heparin-induced antibodies, bind to the blue patches. And these differences explain some of the differences in the biological behavior, but also in the assay performance. Washed platelet assays are important to confirm these antibodies, and these antibodies activate platelets, sometimes in the absence of any cofactor, and completely opposite to heparin-induced thrombocytopenia, heparin is inhibiting platelet activation by these antibodies, while addition of PO4 strongly enhances the reactivity of these antibodies. And very important observation right from the beginning we made with the first patient was that high-dose IVIG is blocking the reaction. And this was the rationale to introduce high-dose IVIG into treatment of those patients, and together with therapeutic dose anticoagulation, IVIG is currently the mainstay of treatment. For those of you who are interested in the recent guidelines and recommendations for diagnosis and management, especially in countries with different resources, I refer to this forum paper in JTH, where we teamed up with a group of colleagues to summarize the most relevant recent literature. And to the best of my knowledge, this is currently the most up-to-date recommendation. I would like to address now the unexpected. And this was that some patients present with headache in the second week after vaccination. Headache is very frequent after vaccination, but usually and typically occurring during the first 2 days. Headache during the first 2 days is completely harmless, but headache occurring in the second week, especially if it is persisting and really severe, is a medical emergency, as shown with this 40-year-old woman. She presented with headache as in 7 days after vaccination. Her platelet counts were borderline decreased. CVST was ruled out by CT scan, and she was discharged on painkillers. This was not a good idea. 3 days later, she was readmitted with a Glasgow Coma score of 12, thrombosis of the right jugular vein, pulmonary embolism, and platelet counts of 35, D-dimer levels of 34. She then developed secondary cerebral hemorrhage due to CVST. And we have gathered a whole series of patients in the country who all presented the same. And those patients who had been sent home only with painkiller and symptomatic treatment, more or less all came back with new developed CVST, and those who had been treated right away with IVIG and an alternative anticoagulant did not develop CVST. Thus, CVST in the subgroup of patients is preventable. The second surprise has been worked up by my coworker, Linda Schönborn, who showed that these antibodies are transient. So although they are a secondary immune response, these antibodies don't persist after about 3 to 4 months. The functionally relevant antibodies are all gone. ELISA persists longer, but this is a ceiling effect of the ELISA. The antibodies really decline over time. Very important, VITT patients can receive a second vaccine shot with an mRNA vaccine or without boostering the immune response. But in those countries who still use the AstraZeneca vaccine, I would recommend to keep a distance between the two vaccine shots to avoid vaccinating someone who is asymptomatic and has circulating platelet activating antibodies a second time with the vaccine. So from the clinical side, VITT is caused by anti-PF4 antibodies. Microtiter plate anti-PF4 assays can detect these antibodies. The PF4 binding site of VITT antibodies is the same as the heparin binding site, and in vitro assays, heparin is inhibiting platelet activation by these antibodies. And my personal opinion is that heparin can be used, and especially in countries where no alternative anticoagulants are available, heparin should be used because early treatment of these patients is key for better outcome. Functional assays confirm these antibodies, but they are not widely available. VITT can occur as thrombocytopenia only, and if patients present with severe treatment-resistant headache, this is a medical emergency. And the good news is that in the majority of individuals, these antibodies are transient. I will now switch to the more molecular part of VITT. Currently, we understand VITT as a two-step mechanism. The early part of the disease is antigen formation during the first 1 or 2 days after vaccination, and production of an immunological danger signal, which is necessary to prime the B cells which produce anti-PF4 antibodies. Then about 1 to 3 weeks later, highly pathogenic, high titer anti-PF4 antibodies are formed, which then turn on the entire clotting system with a self-enhancing state of an amplifying state of thrombosis and prothrombotic disease, and this results in the full picture of vaccine-induced thrombocytopenia. Now, the first 2 days, what is happening? That's a laboratory experiment in which we can measure the size of particles called dynamic light scattering. The 90 nanometers is, when we measure the vaccine, the 19 nanometers is the size of an adenovirus. When we then add it to the adenovirus in the vaccine platelet factor 4, the complexes became larger, indicating that PF4 and the virus interact. When we then added a monoclonal antibody against PF4, the complexes grew, showing antibody binding. We then purified the antibodies from the VITT patients, and they also bound to the same extent as the monoclonal antibody. And this is one of the key experiments. We then added DNA, and these complexes became really huge, and all of this was charge-related because heparin is dissolving everything. Another argument why heparin is probably a very good treatment in this disease. We then went further to super resolution microscopy, and in magenta we stained here virus proteins, the hexon protein. And in green we have labeled our PF4. And you can easily appreciate that PF4 associates with the hexon proteins and the virus. A consortium from the UK and the US with Alex Baker as the first author, generated during these months the best super resolution electron microscopy pictures of the chimpanzee ChAdOx virus, and they modeled the charges on the virus, and the red patches here is all negative charges to which PF4 binds. And this has a large similarity to binding of PF4 to other negative charges, either on heparin or on bacteria, which are very well described. This is again a picture now from our laboratory, showing that when PF4 is given to the vaccine, large complexes are formed. And green is again PF4, and magenta is again the hexon protein. And we are really proud of that the blue spots here, these are the antibodies of the VITT patients, the affinity purified anti-PF4 antibodies which bind to these complexes, which is direct evidence that PF4 interacts with the adenovirus particles of the vaccine, and then the antibodies bind, forming immune complexes which then activate the system. And we look by electron microscopy to the vaccine. This is the chimpanzee virus, but you can see around a lot of amorphous material. And when we added PF4, this amorphous material started to form large aggregates. And these aggregates, again, contain the hexon protein, and they contain platelet factor 4. So reconfirming what I've shown you by DLS before and by super resolution microscopy now on the electron microscopical level. Where is the co-inflammatory signal coming from, which we know is required to trigger B cells to produce anti-PF4 antibodies? The AstraZeneca vaccine is not very pure. When we did run a silver gel, this didn't look like a pure vaccine with virus. There's a lot of other proteins. So we analyzed these proteins by proteomics. And all the blue spots, these are the adenovirus vector proteins. But all the other spots, the green spots and the gray spots especially, are proteins from the hex cell line in which the virus is propagated. So the half of the proteins in the vaccine are not virus proteins, they are contaminants from the cell line in which the virus is propagated. When we did the math on the virus proteins, it was also clear there must be a lot of free virus proteins in the vaccine which are not assembled to a virus yet. And it is known that free virus proteins and degraded cell proteins can induce an inflammatory response. A second parameter is important for the AstraZeneca vaccine. It contains EDTA, and EDTA causes vascular leakage because the integrity of capillary endothelial cells is maintained by VE caterin, which requires calcium. And when a depot with the vaccine shot of EDTA is set, then the calcium is bound and the capillaries become leakage. And this is shown here in the mouse model for EDTA, and it is shown for the vaccine. And we have shown this also in other animal models which completely confirm this. And in fact, 30 minutes after vaccination, we can find in the mouse the vaccine in all organs. They distribute all over the organism. And in some humans, this causes severe inflammation, as you see here with swelling, these red patches like immune complex disease in some of the patients at the second day after vaccination, which completely disappeared a couple of days later. Now, we deliberately took these PF4 antibodies from the patients which did not activate platelets in the absence of any cofactor and searched for cofactors. And as it is well known, PF4 is a strong cofactor to activate platelets, but also DNA. Remember that I have shown you that DNA made the complexes much larger, and DNA is also enhancing the reaction. So the question was, where is DNA coming from in the body? And we have a major source of DNA. These are granulocytes. When we incubate granulocytes, neutrophils, and platelets and VITT serum, the granulocytes undergo mitosis. They release a lot of DNA. It is known that PF4 binds to DNA, the antibodies bind. This forms huge immune complexes which massively activate monocytes, granulocytes, platelets, and endothelial cells. That this happens in vivo, we have shown by measuring markers of mitosis in VITT patients, which are strongly elevated. And we were lucky that we could analyze the cerebral vein thrombi of patients with VITT, which had been retrieved by the interventional radiologist. And so we got fresh thrombus material, and when we stained this for net markers, they are full of nets, underscoring that what we have seen in the test tube is really happening in the patients as well. And this cascade of platelet activation, granulocyte activation, endothelial cell activation is causing a similar self-enhancing vicious circle of thrombin generation as it is well known in HIT. And the straightforward treatment is anticoagulation and blockade of the Fc receptor. There are a few unknowns. And this is a patient we have just published. An elderly woman, she presented a couple of years ago with DVT, then a year later with recurrent DVT, and look at the platelet count, who decreased and decreased, and she was first treated with apixaban, then with vitamin K antagonist, then she came with pulmonary embolism, she received glomerular heparin, and at that time, a HIT test was performed. It was strongly positive ELISA, but the functional test was negative. And then she developed stroke. She did not have COVID. She was not vaccinated at that time. And when we went back to the freezers and retrieved the material from this time and we started to test it with the PF4 enhanced assay, she showed the exactly same pattern as the VITT patients. And this is the laboratory pattern. The serum of the patient or the purified antibodies reacted strongly with PF4, and this was inhibited by a monoclonal antibody we have generated together with Yves Correl from France, who recognizes the VITT antibody binding site. And on the right-hand side, you see the serum of a VITT patient, which has identical control. And this patient had a monoclonal gammopathy, and the paraprotein caused this reaction. It has a VITT antibody-like reactivity. And the unknown situation in the moment is whether there are potentially more patients out there with recurrent thrombosis who have this type of antibodies. And the second unknown, where we are currently intensively working on, is this is a platelet. And this platelet has PF4 on the surface, and it has the adenovirus from the vaccine on the surface. And together with Dr. Nicolai from Munich, I have now shown that platelets transport the virus to the spleen where they present virus epitopes and virus proteins together with human platelet proteins to the immune cells in the spleen, and this may help the B cells and prime the B cells to produce platelet autoantibodies and trigger some of the ITP-like pictures one can also see after vaccination. So in summary and conclusion, it is caused by anti-PF4 antibodies. Human proteins and EDTA likely contribute to trigger the immune response. Anti-PF4 autoantibodies activate platelets, and activated platelets recruit granulocytes. Mitosis amplifies the reaction and causes a major thrombin burst. Unclear in the moment whether VITT-like antibodies are present and are a risk factor for recurrent thrombosis in individuals who are not vaccinated or not vaccinated with this vaccine, and whether these vaccines can also trigger antiplatelet antibodies by hijacking platelets as antigen-presenting cells. And I had the privilege to present you these data who had been gathered by a group of more than 65 scientists in Greifswald and friends of ours who gathered together immediately from March to May last year to generate all these data to unravel the pathogenesis of VITT. And here is, I would like to thank you very much for your attention.